Okay, so I guess I will start because we've had a few minutes, unless my panel members would like to say for me to wait for a couple more minutes, but I don't want to make people wait, seeing as we're at 2:04 at this point. So first of all, thank you for coming today, everybody. Managing the case for shared decision-making in opioid use disorder care. This is a national case-based discussion with community and clinician experts, as well as experts from the drug using community. So I'd like to thank everybody for coming today and welcome everybody, and also do a land acknowledgement. And so I'd like to start by acknowledging that the gratitude that we are coming from together today as people who live, work, and play on unceded territories and treaty lands of Indigenous peoples across Turtle Island. We must recognize the health and social harms that we work to address and are part of the colonialism and its enduring practices and approaches and ways of knowing. So together we must all commit to making sure that we move towards decolonizing these institutions and practices, healing and preventing future harms, and creating equitable and inclusive spaces or access to spaces for care. So everybody, please take a moment, if you don't mind, to reflect on what I've just mentioned and acknowledge where you are and joining from, and the impact of colonialism on the work that all of us do across this country. So I will say that my name is Natasha, and so first of all, I'll start with, can you please, if you want to introduce yourself in the chat, please put your name and whichever land you're coming from, and put your acknowledgement in there, or your position as well, and let us know where you're coming from and who you are. Beyond that, my name is Natasha Touesnard, and I am the Executive Director of the Canadian Association of People Who Use Drugs. And I've been working with this organization for many years, and love my job. We stand up for human rights of people who use drugs, and I'm happy to be here today. Previous to this, I also was I ran an opioid agonist treatment clinic. So I'm familiar with this topic, obviously, if I've been in that space, and I'm very passionate about this space as well. So I will kick it off to Emma, because I think I just introduced myself. Emma, did you want to take over?
Thanks, Natasha, and thanks for opening us up, and welcome everyone, and thanks for taking the time to, explore this really important topic with us. Also, my name is Emma Garrod. I am zooming in from the unceded traditional territory of the Musqueam, Squamish, and Tsleil-Waututh people in Vancouver, from Vancouver. And I am a nurse by training. I'm currently working as a clinical nurse specialist with the First Nations Health Authority. And I'm really honored to have been invited to co-moderate this session with Natasha, and joined by all of our amazing panelists. So just before we get to introducing the panelists, I'm going to go through a few items. So because this is a regular Zoom, just try to keep your microphone muted. And you can keep your camera off too, if that's comfortable for you. Chat box is live, so please enter your introductions and land acknowledgement if you'd like there. And then when we get into sort of a question and comment period, you can feel free to type them up in there too. We have dedicated time at the end to take audience questions and comments. This is a big topic, and it can touch on many things for people. And so if anything challenging comes up for you today, or if there's anything that needs following up on, just please feel free to message Natasha or I privately, and we can connect with you in the moment or after too, if necessary. We do have a certificate of attendance available for today's session, whether it's for course credits. Partway through, we'll share the link, and you just need to fill out your name and email, and you'll get a certificate after the session. There's also a pre-post evaluation survey, which enters you into a draw for one of two $50 gift cards to your choice of Starbucks, Indigo, or Amazon. We'll also be asking a few poll questions, and feedback is so important in terms of informing future sessions. And then, over to you, Natasha, and then we'll do panelist introductions. Oh, you're muted.
Yeah, so the mute button gets me every time. Sorry about that. So I'd like to start with today's session is funded by Health Canada through the Substance Use and Addiction Program as part of a larger knowledge translation project. And so the views expressed here today do not necessarily align with Health Canada, but we're very grateful for the funding to be able to have this session today. So today's webinar is designed to bring people together from community and clinician experts to explore, debate, and collaborate on hypothetical, I say client, but it says patient. So it's client, patient / care. And so we'll debate and collaborate on the hypothetical client patient care case about opioid use disorder, which a lot of people who use drugs don't necessarily like that title, but that's what we're going with. That's where we're flying. So together, panelists will discuss how to meet with both client / patient care and provider concerns. We will be digging into how to enhance the patient's client treatment and management for opioid use by focusing on flexible and person-first approaches to care. And that's exactly why I'm saying client instead of patient, because oftentimes a lot of people who use drugs feel like patient is paternalizing, and it's not in line with how we feel as people. We want to be called clients, not necessarily patients. So we will start with brief round introductions from our panelists, and then we're going to jump into a case presentation. There's 2 of them, but we'll go through one of each of them, and they're about 20 minutes each. Panel and then go through questions for the panel, with an opportunity for the audience to give questions as we go, and then we will move into a second case, as I just mentioned, presentation. Again, followed by the panel discussion and then a Q&A. And I'll kick it back over to Emma, but sorry to change things up on the fly, but I just wanted to mention that a lot of people who use drugs don't like being called patients. They'd rather be called clients.
I love it, Natasha, and I love what we're already getting into here. Even the use of the term opioid use disorder. So yeah, that comes up during our case. Welcome any commentary on that too. So yeah, my pleasure to introduce our amazing panelists today. So I'll just call on each person, and they can share the lens that they bring to this work. So we'll start with Matthew, who really has been a leader in bringing this whole panel and session together. So please introduce yourself, Matthew.
Thanks, Emma, and thanks, Natasha. So as everyone knows, my name is Matthew Bonn. I use the pronouns he, him. I'm the program manager with the Canadian Association of People Who Use Drugs, among many other hats. But I'm also someone who uses drugs and have been on opioid agonist therapy, safe supply. I think I've been on practically every medication from, Metadol, D, methadose, the methadone pills. I've been on Sublocade, Suboxone, hydromorphone. So I really have a wide range of experiences in strict kind of restrictive opioid agonist therapy settings, and also more loose community-based ones as well. So that's the lens that I'm bringing today, and I'll pass it back over to you, Emma.
Thanks, Matthew, and thanks for all your leadership bringing all of this together. Really important work. Jac.
Jac, you're on mute.
Just trying to see if I can unmute Jac.
There, did that work?
Yes.
Okay, so sorry, I changed my setup here while we were talking. I'm Jac Atkinson, nurse practitioner, working in Halifax, Nova Scotia, and I work for a mobile outreach street health program providing primary care, hepatitis C treatment and support to people in our area. And thanks so much for having me.
Thanks,
Jac is also in Nova Scotia, like Matt and I, and I've worked with Jac, and she's amazing. So I'm happy she's here today.
Oh, thanks.
It's nice to see you.
That's nice. Good to see you too.
Thanks, Jac. Iye.
name's Iye. I'm a site worker. I'm also on Safe Supply, and I've been working on reduction for the past 5 or 6 years. I just think it's really important that I'm here as a Black woman, giving a perspective on this case study, and
I think you're breaking up, Iye, there. I don't know if other people thought she was breaking up, but I think she did.
Yeah, I had that too. I can never tell if it's my internet or others. So
Same here.
maybe we can come back to you, Iye, just maybe move to a different spot, and then we could just hear from you again. It'd be great to hear all of what you said there. Alana.
Hi, everyone. I'm so excited to be with this pan-Canadian group of incredible people. And thanks everyone for attending. I'm a settler on the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh people in Vancouver. I work as a family doctor in Vancouver's downtown east side at Kilala-Lalem, which is also an urban Indigenous health and healing cooperative. I'm a UBC clinical assistant professor, and a lot of my work focuses on substance use disorder and trauma. Thank you.
Thanks, Alana. Frank.
Thank you. First of all, I want to acknowledge that we talk about the land acknowledgement, but what we did not do was to include Black people who were brought here involuntarily. So that is something we should keep in mind at all times. When we talk about the land acknowledgement, we have to mention us, my people who came here, as slaves involuntarily. Having said that, my name is Frank Crichlow, calling from Toronto. I'm the president of the Canadian Association of People Who Use Drugs. I work at, I do a lot of research work for St. Mike's Hospital, Toronto Public Health, and other Simon Fraser University and other agencies. My expertise today is on what I've done through research and the people who I work with.
Thanks so much, Frank, and thanks for bringing that additional acknowledgement. Really appreciate that. And Monty.
Thanks. Hi, I'm Monty. I use he, him pronouns. I'm an addiction physician in Calgary and Edmonton. Today I'm speaking of Treaty 6 territory, home of the Cree, the Dene, Dakota, as well as the Blackfoot. And so again, very grateful to be here amongst numerous panelists that I admire, and thank you for having me.
Thanks, Monty. Iye, do you want to say hi again? See if we can hear you a bit better.
can you?
It's still cutting in and out a little bit. It was perfect before we had everyone join. Maybe our tech support, Lizzie and Maddie, could connect with you a little bit and see if there's anything we can do to work on that. And then when we get to the opportunity to share on the case, we could have your introduction at that point.
Iye's done webinars with us before, and this has happened. I think it's your building. It's all like it just sort of encapsulates her. And but Iye's an amazing speaker, and I wish that your internet would work right now because she has so much to offer to this space.
Yes, thanks, Natasha, and I trust that too. And I really want to hear from everyone. Iye has put a intro into the chat in the meantime. Thank you so much, Iye. And look forward to what you have to share on the case too. So we're going to jump right into the first part of our case. So it's going to be the same person for both part 1 and part 2 that we're going to follow at different points in their wellness journey. This individual is a man named Tyler in his late 20s who's diagnosed with opioid use disorder and hepatitis C. He came into the provider's care about 2 weeks ago following an overdose, an ER admission, and some follow-up at a community clinic. He had been prescribed a microdosing kit of buprenorphine naloxone from the ED for 1 week and is now on 16 milligrams. However, he continues to experience some withdrawal symptoms, including restlessness, muscle aches, and difficulty sleeping. He continues to use fentanyl and diacetylmorphine with occasional benzodiazepine and stimulant cocaine use for pleasure and to reduce anxiety. Tyler's most recent urine drug test tested positive for fentanyl. In terms of his substance use history, he's used opioids for the past 3 years following an injury where he was prescribed painkillers in the form of oral hydromorphone. Tyler has a good social support network of family and friends and has pharmacare coverage through his parents. He's currently precariously housed with his parents and is allowed to stay with them as long as he doesn't use drugs at home. Tyler's motivated to stop using opioids. His recent overdose event was really scary, but his current dose of buprenorphine naloxone isn't cutting it for his opioid use disorder cravings and withdrawal symptoms. He would like to start hepatitis C treatment as well, but has some concerns about the potential side effects. Eventually, he'd like to have take-home doses so he can start looking for work again and have a more normal schedule. The provider is concerned about his ongoing opioid use and missed doses and worries the patient will overdose again in the community. So yeah, we're gonna hear from our panelists and we'll leave the slide up here for other attendees to view still, so you can kind of see what we're working with and what we're looking at. And, you know, you can also have your own thought process around what you might do in this case. And also feel free to pop some comments and questions into the chat. So yeah, we'd love to hear from our panelists. What would be your main priority in supporting this person at this point on their wellness journey? And we'll use the raise hand function. I'm gonna just open this up a bit so I can see everyone a little better.
It's hard with the different screens, eh?
Yeah, yeah. I can see us all now. Matt.
Yeah, so, you know, now I'm not a provider, but, you know, as a patient, I would, you know, I would focus on the patient concerns. You know, what is the patient really wanting out of this experience? You know, they almost had a near-death overdose, so, you know, the toxic drug supply is obviously continuously getting toxic. So can we give them a safer supply of a drug that they can use to get the same effects that they may want to from whatever they're using on the street? Also, they're still experiencing some withdrawal symptoms such as restlessness, muscle aches, and inability to sleep. So, you know, what can we do to make those go away? Because obviously whatever, you know, the 16 milligrams of buprenorphine isn't cutting it. What other medications are available, such as methadone, such as hydromorphone, that we can use instead of a medication that's half par for this patient? And you know, those would be my first concerns, and then I would look at some of the provider concerns.
Thanks, Matt. Hey, Frank, I see you.
Yeah.
You raised your hand there. Yeah.
What I look at is this patient has a very unique case. He has a lot going on for him. When you look at his history, there's a lot. What is the first thing I will do is to have a one-on-one conversation with that patient and try and get him, which Matt already mentioned, on a safer supply. That's the first thing I will do. When you look at it also, he's a new patient for a doctor. There's not much can be done if he goes to a doctor right now, because he has to build up that doctor-patient relationship before he could give him any type of proper treatment. He also has a hepatitis C. Then have to know he goes in a safe supply. I can have him talk to him and see if he's interested in getting treatment for his hepatitis C. Okay, and when good, because hepatitis C, as we all know, they have so many different side effects. So it will be, you know, so whenever he goes into treatment, we want to know if the treatment will be safe. And yeah, that's about it.
Thanks so much, Frank. I think Monty had raised his hand.
Yeah, sure. And happy to go after Alana too, whichever, doesn't matter to me, but okay.
You're unmuted. Go for it.
Perfect. So no, and again, thank you for allowing me to be here. And for me, it's all about making sure we align with what the client's goals are. So whatever they prefer, so meeting them where they're at and what, again, their ultimate goal is, whether, and so for myself as a clinician, it's all about quality of life, whatever that means for the client. And so determining what this client's key goals are, whether they still want to be using, whether they want to be coming off of it altogether, and then also determining what's not working for the client in terms of their overall holistic approach to life. So like, do they have housing concerns? Is there mental health concerns that we need to address as well? Are there other medical needs such as the Hep C that need to be addressed at the same time? So approaching it through a more holistic lens, I think, is key here. I mean, I do want to point out that the buprenorphine naloxone is suboptimal. It's at 16, so there's some movement potentially there. But again, moving to where the client's at and being sure that we're very client centric is the key here.
Thank you, Monty. Alana, yeah.
Yeah, I echo what has sort of come out in what people have said, and I think the word that really stood out for me when Frank was speaking is just relationship. I think whenever a new client comes to us, the first thing is really to build that relationship because it is so fraught. It's a real power imbalance in the way that the current medical model, which is very colonized, is set up. So really establishing relationship, trust, as Monty was pointing out, to really make someone feel heard and to listen to what their priorities are. I think in this case, there's so much room for being able to work with this young man. I think there's so many social determinants of health here that need to be addressed. We mentioned the precarious housing. We don't know what the financial situation is. So making sure we connect this person with people who can help with those social determinants of health, I think will be really important in terms of helping them accomplish their goals. Exploring what some of the root causes were at some point, when that trust is established. It mentions that the opioids were started due to pain. Does that pain still exist? If it does, then Suboxone might actually not be the best choice for this person in terms of pain management. Is that going to lead them to relapse? In terms of safe supply, it sounds like they're quite motivated to stop opioids. If they were not, and if they, wanted to keep you, again, Suboxone might be not the best option. If they did want to be, also getting hydromorphone because it might blunt the effect of that. And really, taking a strength-based approach, as someone mentioned, they have a lot of things going for them. And I think there's a lot of room where we could help this person. But yeah, first and foremost, just focusing on relationships so they know that, whether things go well or not, we're there for them.
Thanks so much, Alana. I see Matt has his hand up again here.
Yeah, and I just want to piggyback off of Alana and Frank's around the relationship. Like some of my best relationships with doctors have been doctors that are willing to listen to me and willing to accept me for who I am. And I think, that's so important when we're trying to figure out what the client concerns are and what the provider concerns are. And, right now, the patient or the client is precariously housed as long as they don't use drugs. So how can we keep them safe while they're safe and housed while they're, still going through this process of not using or using? So I think, it's really important for providers to be connecting the patients or the clients to community-based organizations that are providing needle and syringe programs or providing overdose prevention services or an overdose prevention line. And I think, that goes such a long way. And it just kind of makes you think okay, say if you did overdose at an overdose prevention site and then you remember, oh, it was a doctor that actually referred me to here. It helps start to break down those barriers, those structural barriers of how the healthcare system has historically treated people who use drugs. So I think it's so important that, as clinicians, that what's out there so you can refer people to the services that are going to save their lives.
Thanks so much, Matt. I'm wondering if Jac or Iye wants to add anything in.
I echo everything that was said. It's Jac here. I just saw in the chat there that Zoe put in such a nice point about how do you know they're motivated to stop, or were they only offered the options that were directed to stopping? And I just like the way that's framed, and I think it's a really relevant point. We often offer what we know how to do and what's kind of under policy right now. And that doesn't mean that all of the options are laid out on the table. And so I think some of our best successes are in being super creative and really individualizing each care. And I'm preaching to the choir, aren't I here?
It's always lovely to hear it put in different ways too. And I really appreciate that comment of Zoe's, and thanks for picking up on it, because it's gonna bring it into the conversation as well. Alana, I see your hand up.
Yeah, I don't know if people want this info, but just in terms of if there's like prescribers on the call, or for people who want to know what to ask their doctor for, like sometimes other things that can help with the withdrawal symptoms would also be a medication like clonidine, can sometimes help with like sweats or anxiety, and then just asking for sleep meds while people are sort of adjusting to a proper dose as well are some of the things that could kind of help in this early transition time.
Thanks, Alana.
Mhm.
Hey, Jac, back over to you.
Just a super quickie about the Hep C aspect is that it says the patient's not engaging in Hep C treatment, and that's likely bollocks, because it's just Hep C treatment is often really hard to engage in. And so, I mean, it's pretty simple when a provider can offer it in a really barrier-free way. And so it's just about getting them to the right resource that can get them on treatment. I mean, it should be very simple now.
Thanks, Jac. Yeah, it's certainly come a long way, but still maybe not always viewed that way. I saw you unmuted for a moment, so just want to give you space to share verbally if we can hear you. You're still muted if you are talking.
Also, maybe she could write in the chat if she needs. I really want to hear her opinion.
Yeah. Okay. Thanks, Sarah. Trying to do some troubleshooting. Okay, Iye, feel free to type into the chat, or yeah, calling back in probably is a good option. Do panelists want to add anything else right now? There's some also some good suggestions in the chat around, we touched on already, optimizing if this individual, if Tyler wants to continue to try buprenorphine naloxone, increasing the dose just to see if that can get to a good and comfortable place. Yeah, also just I think as the relationship develops, as the care relationship develops, investigating any other, concurrent mental health concerns or other concerns as part of a holistic approach. And I really appreciate what Tanya put in the chat as well, as where possible, including someone with lived experience in the conversation to help with advocacy trust, or explaining what to expect from a deeper understanding. So not available to everyone, but where possible, like such a really powerful way to build trust too, right? Where you can kind of share in that relational space together. Matt.
Yeah, and just for the sake of the argument, I'm going to say, like, let's assume that he doesn't want to stop using, right? It also did say that he's still using benzodiazepines and cocaine recreationally for pleasure. So I think, I don't think there is a goal for abstinence with this patient. And I don't think, increasing buprenorphine is going to eliminate all these kind of concerns as well. And I think we see this happen too much with the providers, where oh, you're not on enough methadone, you're not on enough buprenorphine, let's just up your dose, right? And you know, as patients or in clients, like it's hard to advocate and argue for against somebody because there is that power dynamic as a provider and a patient. So it's really hard to say, no, I don't want to be on more buprenorphine. I'd rather try Cadian or I'd rather try hydromorphone. So you kind of go along with it, and that's when people die, right? Because they just stop taking their dose, and then eventually they'll go to what they know what's best, and that's the street supply. And you know, I think I've lost way too many people that have been engaged in care, but engaged in a care for that is going to alleviate provider concerns and not client concerns. So I think we really need to look at it in a person-centered way. And before, you know, we can slowly microdose somebody off of buprenorphine and put them onto methadone and do it in a safe way. And until I don't think we need to up doses all the time. I think we need to get the right dose of the right medication for each patient.
Thank you, Matt. Are there any other comments or questions from attendees? Feel free to type in. Just checking that I've seen all the that we're up to date with them. And any other comments from panelists as we wrap up this part of the case?
I think Lizzie is saying she wants to say something in the chat.
Okay. Lizzie.
I don't know why it said that. Sorry. I don't know where that came from. I don't need to say anything.
Well, you're very welcome if you do. Thanks.
Okay.
I think it may be Iye because when I signed in, it signed under Lizzie.
Oh, okay.
Oh,
Yeah. Sorry, it's I signed in and it has me under the, Lizzie's name for some reason.
we can hear you. Woohoo.
Okay, perfect.
Take your time.
So one of the things that I just wanted to start off saying is that when a person is coming into a setting, especially a medical setting, I think the first thing that we need to address is that it is a safe space. A lot of us are coming into these spaces, and I say this because I am on Safe Supply, come into these spaces and we are already coming with trauma from, you know, just being a substance user and what that looks like. So addressing that it is a safe space is a really big deal. Also too, I think it's really important to let the patient know or client know that using substances is your right. And if that's something that really isn't the huge problem at hand, it's no shame, no guilt coming into that. Because a lot of the times people assume that if somebody is trying to get support in this area, that they're automatically wanting to stop using substances. And that's like the number one thing when it's really not. It's to get support with, like the person said, chronic pain and pain management. So I just wanted to say that that's like really important, especially because we're dealing with people that deal with stigmas every day in every aspect. And yeah, that's what I have to say.
I'm so glad we can hear you and hear what you had to share on this opening part of the case where we meet Tyler at this point in his journey. And so I'm just going to summarize some of the pieces. I really appreciate Lisa highlighting Matt's comment around alleviating client concerns, not provider concerns. So thank you for that. So I think, yeah, we've heard lots from all the panelists around really the relationship being first and foremost. And I think that's just always a powerful tool to remember that engagement, that relationship is the piece that will keep someone coming back and connecting with care. And that's the thing we want the most. Like Matt said, you know, lots of people end up disengaging, and that can happen for a variety of reasons, but that relationship can be really protective there. And Iye's comment around creating safe spaces, and there's a lot of work to do in terms of creating safe spaces, and there's lots of learning people can do around that. But I think it's a lot of self-work for those of us who are providers, and just considering, the power dynamics in our relationships, and also continuing to ask and learn from the people we work with, asking for that feedback and trying to get a sense of what does create a safe space for somebody. And I think, again, really hearing from everyone around really starting with the patient, the individual, the person's goals, and trying to get, I think it can take a number of conversations or different ways of going about it, really trying to get a sense of what that is. Are they stating goals that they think the provider wants to hear, or that they think are the only options for goals, kind of orienting towards that abstinence-based approach, and, orienting more towards medications rather than safer supply. And so really trying to get a sense of, where are those goals coming from, and what, at this moment, what are truly originating from Tyler, and that can change over time too, right? So I think that needs to be always a part of conversations and encounters that we have as we work with people and work together. And then I think lots of great ideas around options to try with Tyler based on those goals. So really starting from where those goals at, and maybe the right approach is increasing the buprenorphine naloxone dose, but it may not be. And so really keeping all those options open and making sure Tyler knows what all those options are as that relationship and that trust is built. Knowing that it can be, hard for people to say that maybe abstinence isn't their goal right now. And that there can be, a lot of shame and as you mentioned too, trauma that people are coming in with, and there haven't necessarily been that many safe spaces for people to share where they're really at. But that as providers, when we share community resources, when we maintain that open stance, when we refer people to harm reduction services, as Matt mentioned, that can really be a piece of building that trust and affirming where that person is at on their journey. So I'm going to pass it over to Natasha as we move into the second part of the case. And thanks so much to all our panelists and folks also commenting in the chat.
And I found my mute button this time, like there's no delay in me responding. But first I'd like to start, because I did start with a national land acknowledgement, but I'd also like to say that I'm on the land of Mi'kmaq, which is the unceded and ancestral territory of the Mi'kmaq people. And beyond that, as Frank had put out earlier, that I further acknowledge that people of African descent have shared our lands for over 400 years in Nova Scotia, and over 50 strong, resourceful African Nova Scotia communities exist today. And so I just want to make sure that we're also acknowledging the ACP community, because it's very important, considering all of the harms that they've been through along this journey that is Canada now. It was Turtle Island to begin with, but now it's Canada. So I just thank you, Frank, for bringing that up. I very much appreciate that. Beyond that, before we move into the next segment where I'm supposed to do the case summary too, I just wanted to say, first of all, I'm a person who uses drugs, and I am a person who was on methadone that went into had QT prolongation of my heart that had to transfer over to Suboxone. That didn't work for me. It gave me hypernemesis and like various psychotic disorder things. And so my doctor at the time, Dr. John Fraser, who Jack knows, who also Matt knows, he the first time he ever developed a treatment for me, it was Cadian. And if I didn't have Cadian, it wouldn't have saved my life. And so I sit here today because Dr. John Fraser saved my life in that instance. So I just wanted to, before we go into the next case, I just wanted to say that, because I don't think that a lot of people understand the power of what a provider can do to an individual. It can change their life. And here I sit today as an executive director of an organization with Jack, who was my former co-worker when I worked at Mainline, and then Matt is my employee today. So I think those are very powerful moments that people should take with them when they leave here today. So I will now stop gloating over the people that are here with me from Nova Scotia. Pump it up for Nova Scotia. Anyway, case summary 2. Over the last 7 weeks, since our last check-in with the provider, we've tried to increase the dose of Suboxone or like buprenorphine naloxone with Tyler. He was experiencing withdrawal symptoms. So they decided to switch medications to methadone. And Tyler is now on 85 milligrams of methadone, daily witness ingestion. And he reports that he's feeling comfortable now instead of, when he was on buprenorphine, he wasn't feeling that comfortable. And as more regularly has better sleep. So he's had 2 positive UDSs, and that's urine drug screens that for people that don't know the acronym, in the past month, and has had only 1 missed, dose of methadone, which is amazing, really, when you think about it. So he says that he's using fentanyl very rarely, and now that he's increased, that the dose is increased, sorry, excuse my language, I'm flipping over my words, of OAT, he's reduced his withdrawal symptoms. So after doing a benzodiazepine taper, he was prescribed by the provider. Now he uses benzos frequently. So he also uses stimulants infrequently as well, which is an amazing thing. Treatment can do a lot for a person that wants to change their life. I don't mean change their life. If you want to use, that's fine. But if you don't and you want treatment, it's like amazing for people. The provider is concerned about the risk for diversion, which, anyway, I'll make a face about that. Take-home doses, since Tyler has only been on methadone for 6 weeks and only really just started to stabilize. So the provider is also concerned about the HCV, reinfection, and immunity, and would like to ensure that Tyler is able to get regular liver checks and has access to sterile equipment, which I think for people who use drugs, that's not far-fetched. We get that on the regular. Tyler is also keen to have take-home doses, which of course he should, but he has an opportunity doing odd jobs with his uncle and contracting, and he doesn't know how he'll be able to make it too early morning to the pharmacy, which is a common thing between people who use drugs that are like, I think I said it the last meeting we had to everybody, people in Nova Scotia say when they're on methadone, it's called liquid handcuffs because they're married to the clinic and they can't move outside of that. But also beyond that, if people want to get back to a regular life, it's very hard because there's this graduated process that people have to, go into. And so I'll kick it off because now I'm supposed to go to the panel discussion. Sorry for giving my 2 cents on all of this, but I'd love to hear somebody else's opinion on this. Any hands? Oh, Monty, go ahead.
Okay. I'll take a stab at this, and I'm probably just going to address a small part of this and leave it up to the panel to discuss more of these things. But I think one of the points of this is with the CRISM and Optima trial is that we do know now that daily witness dosing isn't key, and it's not going to be helpful to a lot of people, and it's actually going to be a barrier. And we know this from the get-go that it's a barrier. I've heard it from my patients all the time for them to have stability in their life, in their school life, in their social life, which are all key factors in overall wellness. But we all need those pieces to have a reasonable quality of life. And so in order to remove those barriers, we need to be more flexible with the dosing, right? Even from the get-go. So I remember earlier with the previous case as well, kind of touching on this, the individual was on 2 weeks of daily dispensation of Suboxone. And the question is why? I did some training in Boston. We would give four months of dispensions right off the get-go of that medication for people who are experiencing homelessness, who didn't necessarily have all these other restrictions that we have to have around buprenorphine, such as having a home, having a locked box, all those key pieces. With methadone, we have evidence now from 2 major studies now that show that in fact, by not daily dispensing, we actually increase the risk of mortality, we increase the risk of death, we increase the risk of more relapse. All of these things are key things that we are trying to avoid as clinicians, but we end up causing more harm instead. So it's really key that we sort of retailor our practices, and it's hard culturally for many clinicians to sort of change. And I think that's part of this discussion today, sort of encouraging, looking at the evidence, looking at the data, and encouraging all of us to sort of take a step, towards a different direction than we're already practicing, because we're so used to practicing a certain way. I'm gonna leave it at that. There's a lot of other points to talk about, but I'll leave to the other panelists to discuss. Thank you.
No, thank you so much, Monty, because I like this, that, you know, that is a very good analogy of what's happening in our landscape. And so I don't know you that well. I've only met with you a couple times prior to this. I think you know that. And it's very encouraging to hear you speak like that, especially as an addiction doctor, to speak openly about what is wrong with our system and what needs to work. And so I thank you for that. And so go ahead, Alana. Do you have your mute? Where are you?
Thank you.
I know Jac. I'm going to call you eventually because you haven't talked a lot. But go ahead, Alana.
So yeah, I'm really I love this conversation because it is. I feel like it's one of the most difficult positions as an addiction doctor, and especially it is really where you feel that that power differential, and it's one that I hate. But also, I think it's tough, like because I have a really good relationship and a really trusting relationship with a lot of my patients. They are often open with me and will tell me that they do sometimes share their medications with people. And they do it usually out of love because they see their friends in withdrawal and they want to help them. And I really, really struggle with this because I really, it's like that with any medication. I mean, if I knew someone was like giving their antibiotics to someone else, like we're trained really hardcore as doctors to like give specific medications for specific diseases to specific people, and to be very cognizant that like every medication comes with its risk. And so it does really concern me. I think it's different for Suboxone. And why I love Suboxone is because there is less concern for me of diversion because there's less overdose potential with Suboxone. And so, yeah, when I give methadone, Acadian, or fentanyl patches now, I do still do daily witnessed, but with working towards being able to do take home, and I do it in a graduated fashion in conversation with a patient. I don't have to have a patient be completely off of every illicit drugs, but I have to have enough trust with them that I know where they're at, that I know that they can be careful with their medications. And I hear you, like it sounds very patronizing, even as I'm saying it, I get that. And I don't know if it's just because it's been so deeply ingrained in me or because I feel such a sense of responsibility over giving people medications that I know if they fell into the hands of the wrong people or into children, but yes, it's a slow process for me. And what I've tried to do is just be more flexible in having conversations and maybe saying, okay, well, you need weekend take home doses. I get that. So you can like be with your family every weekend, or you need take home doses on these days when you go to work or things like that. So just trying to work overtime towards like full-time take home doses. And that's sort of where I'm at in this journey, but I would love to hear people's thoughts.
Thank you so much. And so I just want to add something to that before I go to Matt and then Iye. There's no protocol around Cadian when I first started taking Cadian in Nova Scotia. And so Dr. Fraser, because obviously he trusted me and he gave me full carries right away. The first patient in all of probably Atlantic Canada that ever started that. And I look back at that and he trusted me. And that's what most physicians and prescribers, nurse practitioners should always do, is trust the individual instead of trying to not trust them. And then if we look at COVID, for example, COVID, made carries go like into high effect all of a sudden. Nobody knew that they were going to happen. So it's like, nobody can come to the clinic. We don't want to get COVID. So we're going to give everybody carries. And what happened? I don't think, like in the clinic I worked in, there was no individuals that had done anything that was adverse to them or diversion to other people. And so we saw like probably over 90% of our clients at Open Door Clinic at that time take carries and do well. And so, but then after the COVID pandemic had been pulled back, they took their carries back from them, and then they did not do well. And so we have to think about this as across the board. I get where medical professionals are coming from, but at the same time, we also have to think about the client perspective of like their life is moving on. They have carries, they can work, they can make their life better. And I'm going to call on Matt now. I'm going to shut up, and then I'm going to call on Jac because I know she hasn't said much, but Jac is like my peeps.
No, thanks, Natasha, and sharing a little bit about your story. And I've become very familiar with it. So, and I do know Dr. John Fraser, and as we know, my doctor's close to Dr. John Fraser as well. And I think a lot of times back in the day, doctors prescribed hydromorphone as a form of opioid agonist therapy, right? They prescribed the medications that people were using to stabilize them until they could get into a program. And what happened was people did good. They didn't want to come off their hydromorphone. So when the call came to go to methadone, they just said they were fine. And I think, we have forced people to kind of go into this regimen of this therapy when most medications are not prescribed in this very strict way. And I think, for Tyler, right off the bat, I would just give him his carries, right? Like give him, if it's not weekly carries, give him bi-weekly carries, give him every second day carries, just to start to build that trust between the client and the provider, so they can be open and honest with you, and they can say, look, I used today and I may use tomorrow, instead of, having to go do a urine drug screen and feel all weird. I think the more we can be friendly and have a friendship with our provider, the better care the client is going to get. And I think, we can do a lot of the opioid agonist therapy can be done a lot through telemedicine. We don't need to go in once a week to see the doctor. We don't need to go in once a month to see the doctor. We can be doing this through visits, like 4 times a year. You go in, you do a urine. If your doctor trusts you and you trust your doctor and you can tell them I used, then what's the point of dragging them an hour to the clinic to get a urine drug screen that says they used? So I think, we really got to adapt the way that we have been providing opioid agonist therapy. And I think, we can use tools like telemedicine and take home doses to do that.
Thanks, Matt. And so I've seen the chat and I've seen Zoe had said something there too. I mean, Zoe's really correct in this when she says optimal would show what people who use drugs want for OAT, has been saying for decades. If addiction medicine listened to people who use drugs, they could have saved millions of lives. And that is the actual, that is what's at hand here when we discuss OAT. Because a lot of people in Nova Scotia is saying is, and I said this when we did our pre-meeting, it's liquid handcuffs. Is that I'll always say that this is what Nova Scotians say is liquid handcuffs. And so a lot of people drop out of treatment. There's no retention for the very fact that they have to go to the pharmacy every day. And so people just don't, I understand the prescriber perspective. I know I've worked with a prescriber for many years, and I know the levers that happen. And he was awesome to work with. I mean, I loved him. I still love him. And I still talk to him on the daily. But, it's sort of just drop down some of those requirements for people, because we could do it in COVID. Why can't we do it now when people did well? And Jac, you know what? I don't know. You don't even have your hand up, and I'm going to call on you because you're from Nova Scotia and I have to.
Well, I've just enjoyed hearing everyone's perspective because, I learn a lot from listening to you all. And I think that it's the greatest debate at the moment. And I think that we're all living on a grayscale and trying to figure out. I think one of the things that I like to really push forward is to admit that none of us know the right answer at the moment. There just really isn't enough evidence, and we're all trying to push the barriers of getting rid of the barriers, which I think is really important. And therefore, because it hasn't been done a lot before, we don't know what we don't know. And I think that's really important to admit, but also that there's 2 different perspectives, and they're both really important, whereas the drug user's perspective is just as important as the prescribers, and prescribers are tied to their license and being professional and to be accountable and for safety. And I think that's really important. But I do think we need to decrease barriers within reason. And so I was going to suggest that I would start in little small increments in starting on a every second day dispense, or dispensing over the weekends, or something like that. And then I also would really drive home the use of pill counts. I think that pill counts can be really useful in just kind of showing how things are going without more an accusatory, or, you know, sometimes urines feel really yucky. And so I often use pill counts as more as a discussion starter, not as a, you know, punishment or something. And of course, I'm very interested in keeping people safe and our community safe. And therefore, I don't think we just like let it all go and give a month out at a time or even a week out at a time right away. And we do have to make sure that we're paying attention to our relationships. But I am an advocate for sure of decreasing barriers. And I think that trusting your relationship with the, you know, we're so worried about trusting and figuring out what's actually going on, because we do, as providers, get lied to a lot. And I think that that's a normal thing. But there are so many more times that we're not lied to. And that's what's really important. Like we get really upset about all the times that we do get mistruths. But if we actually wrote down all the times that we were told the truth, if we're actually providing a safe space, then I think we'd learn that more often than not, we're not getting duped. And if we are, there's ways to help with that.
Hey, Jac, I've been with you. There've been scoops many times. Like we've been like, that's just what happens in the nature of the world. But I think there's more people who use drugs in this world that actually use drugs. And if they do divert, and I think this is something that people have to understand. If they do divert, they're providing a safe supply to somebody else that could possibly, and Monty, I'll go to you next, they'll possibly be giving them a safe supply of drugs if it's prescribed. And so while we think about methadone being diverted, a 30 milligram bottle of methadone could kill me. I'm opiate naive. It could kill anybody on this panel if they're opiate naive. But yet a bottle of Dilaudid, if you give somebody a 4 milligram Dilaudid, is it going to have the same effect? But yet we have more apprehension to actually being able to prescribe that, and more levers there. And so I would say they're both, they can both cause harm, but which could cause more harm with a 36 or 48 hour half-life or lifetime for people who use drugs, or people who are opiate naive actually to take. I mean, so when we think about that, why is it that prescribers are so open to prescribing methadone, which actually can kill people on the regular? And let's pump up the jam here and let's talk about it. I mean, it can. I mean, it is a very dangerous substance, whereas I would argue, I only worked with a doctor, I am not a doctor, so disclaimer, but I would say that a 4 milligram Dilaudid would be a lot less harmful to an individual that would take a 30 milligram bottle of methadone. And I will go to Alana, go ahead. Sorry about my spiel.
No problem, but I think Monty was first. Did you still want to speak, Monty?
Just very quickly, I'll make it pretty quick. No,
sorry,
thanks.
I didn't mean to overlook you there, Monty. I forgot. Sorry.
It's all good. No, I just wanted to say, like, I around the topic of urine drug screens, we also use it to penalize our patients, and I think just off of that, we shouldn't be doing that at all. And for us, for example, with buprenorphine especially, we don't actually do urine drug screens per se unless the client wants to know what they're using, what might be contaminants in their supply, if there are contaminants in supply. So those are the concerns those are the issues that we sort of use urine drug screens for nowadays. But then on the flip side of things, especially with methadone, again, we shouldn't be using it to sort of penalize clients, remove their carriers from them, etc. It has to be really there to support them, what their needs are. And so this whole side of punitive medicine, I think, needs to also go, and just wanted to kind of throw that out there. Thank you.
Thanks, Monty. So I had a couple of points I wanted to bring up. One thing, it hasn't been mentioned in the conversation, so just one thing to mention is that one of the things we've done in Vancouver has been to work a lot more closely with pharmacists, and during the pandemic, they became really so much more open to having a delivery model. So that's one thing that we've done to increase flexibility, is be able to deliver opiate-assisted therapy to people in their homes or rooms. And it's not a perfect system. I mean, people aren't always home, and then what happens? But it's definitely been a helpful interim spot for some people. In terms of what you were saying about why some providers feel more comfortable prescribing methadone, which could be more toxic to others than hydromorphone, I think it's partly because of our training originally, like when we started. So it's interesting. I mean, the landscape of addiction medicine has changed so dramatically over the last 20 years, and the teaching and so on. I mean, when I started working, it was like no one cared about prescribing benzos. Like it was, everyone got a benzo prescription, and now it's like the horror. So yeah, things change. But you know, our training has always said short-acting opioids are much more dependency forming and can cause people much more problems in terms of like rapid increased tolerance and dependence because of how they rapid cycle, as opposed to long actings, which will be more likely to give someone the stability to have a more, you know, functional life, if that's their goal. What I've learned over time is that, as Matt was saying, is that's totally not everyone's goal. Certainly for pain, hydromorphone is much more effective because it kind of has an acute onset, like a sudden onset, which is much more helpful for people who are in extreme pain. So it's really tricky, but I think these are all things like that we're learning as we go. So I think it's also about tailoring the right medication to the right person. In terms of the urine drug screens, I completely agree. I think for long-acting opioids, especially if we're already doing like a daily witness, it seems like bananas to on top of that be doing urine drug screens. It does, like, it makes it impossible for someone who already has often, you know, a challenging life to keep up with all the bloody hoops that we make people jump through. Where I work, we are still doing occasional urine drug screens for people who are on hydromorphone. The reason being that they're not witnessed. And interestingly, like, I mean, it's been interesting to see how, you know, every now and then we get someone who it comes back negative, which means they probably haven't taken any for at least the past 3 days. And it leads to some really interesting conversations with people around, you know, people will often talk about like the fact that, yes, I have been selling it. And yes, if you take it away from me, I will have some serious problems as a result of that. Or yes, I do share it with people because I want to help my friends who are sick. And it leads to some really controversial, like, you know, challenges for prescribers. And I think that's the landscape we're in right now, is figuring that out. And it's part of why I really try to push for moving some of these things out of the medical model and into more the social justice model and legalization model, so that it is up to an individual to decide if they need and want opioids, rather than having all that power be in the hands of prescribers. I mean, if someone has an opiate dependence and they want help to stop being dependent on opioids, then that is like, that's what I call, you know, a substance use disorder that they want help with, that I can help treat. If someone, you know, wants to use substances and stay alive, like, then, you know, they don't have a medical problem. Like, I'm in this role where I can help them stay alive. And so that's the place I'm in now, where I'm doing what I can to help people stay alive. But I feel like they should have a right to go out and use, you know, the substances that they want to use in a safe way. So I think we're in a really unusual time. Those are some of the thoughts spinning through my head. And yeah, and so I'm super excited to keep listening, which is why I will be.
Thank you so much. And so I'd like to preface that with, let's start off with the majority of people who use drugs in this world do not have a substance use disorder. They don't have any health consequences for their use. I've been in many projects now, even with like the construction industry and like the apprenticeship, where 71% of people that are in the apprenticeship say they don't have a substance use disorder. They don't have any health consequences, yet they're the highest rate of deaths in overdose. So when we measure that, I mean, that is a big difference. And so people use drugs because of disinhibition, socialization, the same as people drink wine. And so when we have this context, right, when we talk about this, we always talk about what, I mean, Health Canada or other people say is problematic substance use. You know what I say? People have problematic lives. And that's why their substance use can, you know, exacerbate or be harmful to the individual. I do have a question here. I do agree with you, Alana, that we should have regulation. Doctors should not have to decriminalize people who use drugs. That should not, or nurse practitioners. There should not be an encompassment of you guys to like decriminalize this. But in the meantime, we need you guys, right? We do. We need doctors. We need nurse practitioners. We need people to be able to prescribe the drugs that we need. In the meantime, we depend on you guys. And I get you can't do it to the occasional user or people that use on the side, but really for people that have substance use disorder, people should be able to come in and say, I need this drug, not, when I go, I have anxiety, let's think about this. There's 10,000 different drugs I can choose, not 10,000, I mean, maybe 100. I mean, I could go on, you know, all these different drugs for anxiety and depression. But when it comes to opiate treatment for people, there's no choice. There's like 2 drugs generally. And if you want to go on Cadian, it's a very strict, long process now. It's going to be poured into applesauce. And so what does that say about our population, the way that we're treated by, and I'm not saying this to denigrate prescribers. I'm just saying like, this is a reality that we face on the daily, that we're treated differently for the substances that we need to actually live. And not methadone doesn't work for everybody, not just Suboxone, as my story, nor Cadian did. Hey, some Dilaudid would for somebody else. And so we have to understand that there needs to be choices for people. We can't take them from them. Anyway, I see a question here. Sorry, I didn't mean to like go on a tangent again. So somebody said, I'm curious for clients that feel that they don't have the ideal relationship with their provider and are frustrated with their care and lack of trust. What advice would you have for them? I know more rural communities, there are not as many resources for those providers to go to. So I'll put it out to the panel. I see Matt's hand up. I know I've talked a lot, Matt. I'm going to hand it off to you. How about that?
Yeah, thanks, Natasha, and thanks for a great question. And, you know, as I said, I've had so many different relationships with providers, some great, some horrible, but the best relationships I've had with doctors are ones that have hired former patients or former people who use drugs as their case managers to deal with all the office and admin stuff. So, you know, you're not just going to see a provider, you're going to see like a team of people, and they can go into the community and find out exactly what resources there are. Where are the overdose prevention sites? Where are the needle and syringe programs? Is there a safe supply program, you know, and help advocate to your doctor with you, you know, so you start to build that relationship before you even get into the room of that provider. And, you know, I think it has to be a very, you know, centered relationship. You know, it can't be a power dynamic. It has to be, you know, you, the worker and the provider all making decisions that are client centered and person centered for yourself.
Okay, I'm a moderator again. I'm going to be an adult. So I'm calling my panel, my adult panels. Is there anybody else that wants to respond to that question? Go ahead, Jack. I'm happy my Nova Scotia people are showing up today.
Well, I just wanted to say, in relation to that for providers, I think as providers who work in addiction mental health, we do have such a responsibility to mentor and support other providers. And I think it's really important for all of us to remember that in different communities, particularly rural, like you're saying, that the resources and comfort level aren't there. And so I believe we really need to reach out to our colleagues in places that don't have support system, because I think a lot of these archaic boundaries and barriers that are put in place by providers are coming from a lack of comfort with working with this population and with this these medications. And once you become more comfortable, you're much more able to drop some of these barriers, because it's kind of a matter of like what you don't know, and then once you know, you can figure out where you can move the line. So anyways, I would encourage any providers to reach out, or even the rural providers to reach out and find your community, because with current technology, we have great chat forums and emails, and we're only a call away, and I would raise my hand for anyone who wants to call. And then for patients clients to really feel that you are allowed to choose your provider, and you are not restricted to certain providers. You are, I think a lot of people are because of their location. However, you shouldn't be. And so I think we need to fight for that, you should be allowed to go to what provider feels comfortable, and to those who are used to working in this situation. And we all need to fight for that, to make sure that people are paired with providers that are comfortable and willing and able to work with these really specific complex cases.
Thank you so much for that, Jac. And you know what? I was thinking about, I think Matt made the comment earlier about telehealth medicine. We have rural communities, even Nova Scotia, like Cape Breton. There's so many different rural communities where people don't have access to a physician. And we're so, like, since COVID, we have so many different technologies that we can harness right now. And we can even do it with opiate treatment. I think I said it to the Ally Center before they had Kate, and they were going to do an overdose prevention center. I was like, you just need one doctor that is willing, like, to come train people to do case management, urine drug screening, and be able to report properly within the EMR. And then, have a, teledoctor. I mean, like, seriously, that's all it takes. The community can pick up for this. And I think a lot of people miss that when we're talking about these perspectives. But I know that I've long run over time. Oh, wait, Jac, go ahead. I see your head.
So just real quick, there's that new term called task shifting. And I think that that's really important, that, the providers can be more of a support system for folks who are on the ground and boots on the ground. And I think that people in positions not in medicine can be doing a lot more work, because they're fully capable of doing so, and it's up to us to give them the power. And
hey, Jac, I have no medicine behind me, like, straight up. And like, I had a doctor put a bet on me, and I went in there, and I was the case manager, and I took care of a whole clinic. We had 300 people in there for opioid agonist treatment and family practice. So I know the community can do it, because I am one of the people that are in the community that can do it, and like adhere to the guidelines and the procedures that physicians have to have. So perhaps I should end with that, because I know I've gone way over time. And I'm sorry that I took up way too much time on this. I think it was an important conversation, though. And I want to thank everybody for being very open and honest in this conversation. But I think, when I think about telehealth, I think that's our future, especially for rural and remote, because there's no way to reach them, because there's no prescriber that's going to say, I'm going to move out to a little town and like make no money, right? Like, I see. Okay, Alana, before I hand it off to you, am I going to go to Alana? Go ahead.
Sorry, no, I just wanted to say how grateful I am. Like, it's so helpful hearing your perspective, and and it just makes me cognizant of how much I need to really reconsider the way I practice on a regular basis, and just keep having those conversations with the people who I'm working with. I think it's been a difficult time for providers trying to kind of constantly shift, learn all these new medications. I agree with you. Like, it's such a wonderful thing that we're getting more, but we still don't have enough. And you're absolutely right that if someone comes in with something that's not on our traditional list of what we can use to treat for OUD, we're really reluctant, but we don't treat other illnesses or conditions in that fashion. So I've really come away from this talk, like, just with the desire to stop and think more. I think we've been overwhelmed in our practice, and so sometimes we're doing things because it's easier to just keep proceeding in the fashion that we feel comfortable. But yeah, thanks for sharing your feelings, and I will put more thought into whether what we're doing makes sense. Thank you.
No, thank you for acknowledging that. I think that takes when I look at things, when I'm working with my people, I say, after the fact, like, this is something I should take into consideration. It takes a big person to actually say, hey, maybe I need to actually look at. And so anyway, I just wanted to say, like, I really thank you for reconsidering your position, or not reconsidering, but looking at your position moving forward. It is an amazing thing when people can come into these conversations and look at their life and look at the people they treat and have a different perspective maybe moving forward. So I do thank you for that, Alana. I very much so. And I know I'm kicking it off to you now, Emma. I know I'm supposed to end, but I'm going to give it to you. Go ahead.
Okay. I got the notes. I can do it. This has been such an amazing conversation. And I think, Alana kind of summed up, what we want out of conversations like this, which is an ability to reflect and look at we work, how we are in a different way. I've taken so many notes that I hope to, bring into other work that I do. And I hope this has also been really, helpful for others too, as we continue to work to just challenge the system, be critical about the system, improve the system, and be working together in a good way going forward, knowing that it's been archaic for a long time and there's lots of work to do still. Please, if you have to go, just click on the evaluation link and fill it out when you do have time to. That's just a few comments up here, and get entered into the draw for the gift certificate. And then there's also the link there for getting a certificate if you would like one of those as well. Lizzie's just popped the survey in there again. And yeah, if you have any questions or any follow-up, feel free to contact the organizers. And yeah, just really appreciate all the panelists' perspectives and how open everyone was in the chat and really sharing powerful words. I'm just going to check the notes. I think that covers everything from the top of my head. So yeah, I just huge, Lizzie's put
I wanted to
Janelle in there for any follow-up questions. And yeah, I can pass it over to you, Natasha, for last words too.
Yeah, I just wanted to say, like, as we sit here today and we talk about people who use drugs lives, I think we all have to sit ourselves in the space that we've had like over 30,000 individuals in our country die due to a poisoning crisis. Not because they've done this on purpose. It is an accidental poisoning because they're accessing an unregulated market. And so while I understand that doctors can't prescribe to somebody who uses occasionally, and we're not asking doctors to actually decriminalize us, we also have to recognize that there's people dying for no actual need other than we don't have a regulated market. And I know as somebody who's lost, board member this year, a very dear friend of mine, Monty Ghosh was here. Rebecca was a good friend of mine. She was like one of the co-founders of NORS. I miss her. I was one of the last people that sat in a space with her spotting, and I've taken that back in to wonder if I've done the right thing. Did I miss something? Sorry. I miss her. I miss the people I work with. And there's too many people dying right now. So that's all I'm going to say. So could everybody please have a moment of silence for the Rebecca Alexanders and all my board members that have passed, while Matt and I and all the people that we've worked with have died. Thank you. And I'm really sorry for getting emotional, but it's really hard when we have people like by the thousands that we love dying around us, and we need to pay attention to that, because if we're not there for them, who's going to be, right? And I think Matt can attest to that. I see Zoe in the chat. And Monty, I see him there. Like I miss Rebecca. She was like my good friend. So thank you everybody for chiming in. Thank you. Sorry.
Thanks, Natasha. No need to apologize. This is the heart of the work, and it's important to remember, why we all do this, and what's at the heart of it. So thank you. It's real. And thanks for what everyone has brought and shared from their hearts and their experiences today.
And I think we ended 8 minutes early, even at that. So I think we're doing really good. Sorry, guys, I didn't mean to get really upset, but it's just been a hard couple of years for people who use drugs, with everybody in our community dying. So thank you for accepting us and having us in this space and as colleagues, instead of the downward movement of looking down on us instead, if that makes sense.
Yeah. No apologies necessary. Folks like you and the organizations that people are working for have been doing the real work and keeping people safe for a long time. It's just, it's more like the system catching up to actually include those voices and listen and learn from those voices. So thank you for all the work over many decades now, right? Yeah. Any last words from anyone else? We do have folks still with us, and a few more minutes if anyone else has any final thoughts too.
I'm surprised Matt hasn't come off mute yet because he normally has a lot to say. I think Jack does that. We all know Matt well. He has got a lot to say. So Matt, why don't you have some final words?
I don't like being put on the spot like this, but you know, I think Natasha said it well, that, you know, we can't have any of these events without honoring and remembering all the lives lost due to failed drug policies. And, you know, I think we really have to start holding the healthcare system and doctors accountable for these deaths, and not, you know, the toxic drug supply, because, you know, if people actually had the drugs that they needed and they wanted and that are available, we wouldn't have as many deaths. So, you know, I think it's hard losing everybody, you know, 6, 7, 8 people a day, or in BC 20 or 30 people a day
In Canada, yeah.
You know, so we have to continue to fight against the system and change the way that things are done. And, you know, I think this is the only way that we can do it, and through our collective advocacy, I think things will slowly get better, but you know, it's only done on the lives of people already lost.
I don't know who's supposed to close, Emma. I don't know if it's your job or my job, but I just want to say we're going to stay 15 minutes after the fact, right? In case people need to debrief. But I have to leave because I have to meet with my accountant right after this. So I can stay for like 2 minutes after the fact.
I think there's been lots of really important stuff shared, and really important perspectives on who takes responsibility, and how we can really just learn from each other and move forward in a good way. So thank you so much to all the experiences and all the just really heartfelt words shared by folks. So I think we can close there, and panelists can stay on for a couple moments. Jack has a hand raised. Yeah.
Oh, I just wanted to make sure, Frank, you felt like you could say that. I think you have a really interesting perspective, and I wondered what you felt about that conversation.
Well, okay. First of all, there's so many barriers with prescribers and people who use drugs, and you know, like, I believe, I hope that we can change that system, where we can have a better system with providers and people. Well, I don't want to use the word disorder. I'd like to use the word challenges, substance use challenges. And I've been hearing the word disorder so many times, which drives me crazy. I even text my ED until I don't use it anymore, but she still kept on using it. Yeah, but yeah, it has to change. If we don't change it, death will continue to rise. People will continue to die more and more and more.
And Frank, thank you for that, because he did text me and he'd say, and why are they using this opioid disorder? Like, because him and I both talked about this, how stigmatizing it is to our community in that sense, right? Like, it's pathologizing us. And thank you for bringing up that, Frank. I didn't see your hand, like, because I only have so many like boxes here, so I don't know if you're trying to talk to me through, but I did see your text. And thank you for being here with us today. Thank you for sharing your expertise, because Lord knows we need it. Oftentimes we're not included in these conversations, and I appreciate everybody that's been here on the panel today, because we need everybody's experience, not just even people who use drugs. We need to hear the prescriber, the nurse practitioner, the program manager experience as well. And it's been I'm a little bit upset, but that's just because I've lost a lot of people like you and Matt have. And so I'll go away and meet my accountant a little bit, and I'll be okay afterwards. You know, we suck it up and move on. But Emma, you take over.
Thanks, Natasha, and thanks for those words, Frank.
Thank you.
And to all. So here's to building a better system together. So thanks for joining everyone and sharing. And we'll see you at the next one, hopefully too.
Okay.
Bye, everybody.
Bye, everybody.